Okay, the topic of my talk is medical testing and evidence for looking at medical testing. But to get you started, I also want to find out a bit more about your personal views of what kind of tests you take or would take. So here's one, blood pressure measurement. Think for yourself, actually, did you have a blood pressure measurement in the last 12 months? Okay. I didn't ask, this is anonymous, so I didn't ask for your age or anything like it. But the majority of you did. Okay, second question about lipids, cholesterol. Did you have a cholesterol measurement? Do you know your LDL, HDL, triglycerides based on a measurement in the last 12 months? Wow, that's a surprise to some extent, but we'll continue. And now this is a USB colonoscopy device, actually, that you can buy on the internet. Actually, I'm not going to talk about who bought this over the internet, but let's think about colonoscopy in general. I know the UK has no actually population screening based on colonoscopy. So imagine that I were to offer you free of costs, actually, personal cost of colonoscopy, just for screening purposes and to remove any adenoma or cancer that we can find. Would you take it? And for those of you who think you're too young, actually imagine that you just turned 50 yesterday and were asked the same question. So would you have a colonoscopy? This is very typical for a medical audience, actually. If you ask these questions to different authorities, you get different numbers. I'm going to ask two more. How about individual genome sequencing? It's offered on the internet at some cost. But imagine that here today I were to offer to you your personal genome scan free of cost and to communicate results to you also in terms of the associated risks for the development of diseases and conditions in later life. Would you undergo a genome-wide scan? Okay. And one more. This is a beautiful picture. Imagine that I were offering you to have a similarly beautiful picture, actually, with a poster-sized print that you can put on your wall, and the identification of any conditions that we find on that whole body MRI. Would you take that full body MRI? So 1/3 would. So you see, actually, on these questions, actually, the audience is divided. Some of you would, some of you wouldn't. So there's absolutely some diversity in how you weigh the personal benefits or risks and the personal about these different medical tests for you personally. And we don't have the time to discuss why you would and why you wouldn't, but these are all actually, maybe except for the USB colonoscopy, well accepted devices. And some of you would and some of you wouldn't. I want to talk in the rest of my presentation on how we can find out about the evidence for undergoing these screening tests, but also diagnostic tests. How do we look at the evidence nowadays? And I want to use that by, I want to do that by using a parable in 4 visits. So it's a fictitious story, but to tell, to convey a message or to tell a lesson. So here's the parable, and here's the first visit. And the first visit takes place, as any other visit, in the emergency room of a hospital. And it's a busy emergency room, like any other hospital. And enter Mr. Metabolomics. Mr. Metabolomics has just made an appointment with the head of the emergency room, and he carries with him, actually, a number of issues in his bag. And Mr. Metabolomics starts explaining to the head of the emergency department that he knows that the diagnosis of pulmonary embolism is a very challenging thing. So pulmonary embolism is a potentially fatal condition, but for which there is effective treatments. But you all know, actually, that making a clinical diagnosis is a challenge, actually, and therefore additional testing is needed. And now Mr. Metabolomics opened his bag and he starts telling about a wonderful new development, which is the development of an artificial or an electronic nose. And that is a device, actually, that can detect molecules in exhaled breath. And some of these molecules are associated with pulmonary embolism. And through very sophisticated, advanced statistical techniques, the company of Mr. Metabolomics has developed sophisticated algorithms, actually, that can analyze these molecules and make a diagnosis of pulmonary embolism. And here actually is the device that Mr. Metabolomics actually gives to the head of the emergency department. It's the PE sensor, the pulmonary embolism sensor based on exhaled breath. And then there's a pause, and the head of the emergency room smiles. She's a lady, actually, Hoegeburen, born in Flanders, educated in the Netherlands, and she says, and she points to a sign on the wall. But before she does that, she said, well, your device actually looks very smart. Actually, reminds me of the scanners that we use in our hospital. And those scanners have always reminded me of actually iPods and iPads and all the Apple machines. So they have these smart, actually they're white, they have these rounded curves and they're smooth surfaces. So it looks like a very seducing piece of technology. But there's a sign on my wall that says, "In God we trust, and all others must bring data." So Mr. Metabolomics, I regret that I cannot do business with you. And Mr. Metabolomics leaves the room and returns for a next visit a few months later. Again, at the emergency room, he enters with the same big grin, and he says, "Well, I thought about your remarks, actually, and what do you think about my PE sensor now? Because I've brought with me the following. Lots and lots of data. And based on this data, I was able to get the CE certificate. So I am allowed actually to sell it all over Europe, including your country." But Mrs. Hoegeburen stands up again and she smiles and says, "No, Mr. Metabolomics, actually, as you know, the CE mark actually is a declaration of conformity. It actually tells you that your device actually complies with the standards in the European directive, so you're allowed to sell it in Europe. And that directive actually has 4 risk categories. Actually, your device is in the other IVD devices, and that means that a CE mark by no ways is a guarantee of any quality or any guarantee that this device is fit for purpose, that we can actually use it in the emergency room. No, Mr. Metabolomics, I regret we cannot do business today. Enjoy the rest of your day." And by the way, in this hospital, we believe in the principles of evidence-based medicine. So take these 2 books with you and start reading them. Your company may benefit from them. Okay, Mr. Metabolomics is not happy. He leaves the room, but he returns for a 3rd visit. There he is again at the emergency department, actually with the same big smile, and he has this device with him, and he's feeling very confident. "I've read your book, these books, and they've explained to me that in evidence-based medicine, you do diagnostic accuracy studies. So this device should be treated like a biomarker and should be compared with the gold standard. And I know in your profession you usually do not have gold standards, but you have our clinical reference standards. So what you do is that you take a series of patients, evaluate them all with the biomarker, then the reference standard, and cross-classify the results." Well, Mrs. Hoegeburen, this is exactly what we did. We used our PE sensor in over 2,000 emergency department patients, and we confirmed the diagnosis by a multi-slice CT. And here is my 2x2 table. Yes, Mrs. Hoegeburen, I know about 2x2 tables with true positives and true negatives and false positives and false negatives. And I can assure you this test has excellent accuracy. Mrs. Hoegeburen is not impressed. She smiles and she said, "Well, it's very good that you finished these books, actually, but I think you've missed a few points. You know that we rely actually nowadays on CT scanning to confirm the diagnosis. That is indeed correct. But this is our current pathway actually for detecting pulmonary embolism. First, we start with a clinical decision rule, and if the clinical decision rule, based on signs and symptoms actually, classifies a patient into high probability, then we have the CT pulmonary angiography, as you can see on the bottom of this slide. In all other cases, actually, we rely on a D-dimer test. And if the D-dimer test actually is positive, actually, we also do a CT. If both probability is low and the D-dimer is negative, we rule out pulmonary embolism. So where exactly, Mr. Metabolomics, will your test fit in our current pathway? Are you suggesting that we should replace it, the D-dimer, by the PE sensor, which is one option? Or are you suggesting that we should treat it like an add-on test, to prevent the too many patients that are now undergoing CT for suspected pulmonary embolism from undergoing a CT pulmonary angiography? So that means it should be positioned in the other position. Or are you suggesting that we should replace the clinical decision rule by the PE sensor? And in your accuracy study, Mr. Metabolomics, I didn't see anything about that pathway. Do you know actually that patients, if you look at the relations between medical test and patient outcome, which is what we care about, that there usually is not a direct connection between medical testing and patient outcome? We know about the harms of medical testing. Think about radiation and the risks, the cancer risks that it induces if we use CT. And think about the nephropathy that can arise from using the contrast agents. These are the harms of medical testing. But there are very few direct benefits of medical testing. The only ones that I'm aware of, Mr. Metabolomics, are the reassuring feeling that somebody has if she or he has been examined by a doctor, especially if that doctor has a very low, reassuring voice. So, Mr. Metabolomics, the effects of medical testing on outcome actually are through the test results, because the test results that we receive are used to guide our clinical response, which means treating or not treating the patients. And it's doing the right things in the right people actually that eventually lead to patient outcome. So accuracy is not the critical thing, actually. It's on how tests affect patient outcome in the end, how tests actually improve the health of patients with suspected pulmonary embolism. So these were the three first visits of my parable. And I'd like you to think about how a fourth visit would look like in this world, actually, where we have such a high trust in numbers and we pursue objectivity in science, medicine, and other areas of medical life. We are a society, and as humans, actually, we are seduced indeed by technology and by the beautiful pictures that these forms of technology can produce. But actually, if we're looking at medical testing, we should ask ourselves three questions. One, is the test result that is generated by these tests, is it actually true? And this is summarized in terms of the analytical validity of medical testing. But the second question is not only is that result true, but is it clinically meaningful? And by that, we're referring to the clinical validity of the tests. Can the test results be associated with clinical findings that are relevant to clinicians and patients? But the bottom line is not only whether it is meaningful, but whether it's useful. And that, Mr. Metabolomics, is the clinical utility of medical testing. And I do believe, actually, that we should look at clinical utility in all of your findings. And clinical utility is a term that is used in many, many ways. But clinical utility refers to health outcomes that matters to patients and society. And these health outcomes mean that we would like to prevent premature death, that would like to reduce or maintain functional health in the first place. And clinical utility is also probabilistic. If you undergo testing, you're not guaranteed to get these health benefits. Actually, it's a matter of risk and chances and probabilities. If you take part in screening, it's not guaranteed, actually, that we will detect early cancer in you. It's not guaranteed that you will suffer the side effects. So we have to weigh the health outcomes in probabilistic terms. And when we look at clinical utility, we should also be comparative. We should not focus on the device itself, but we should compare it with the current best strategy for managing that particular condition. So we should not focus on the technology only, but we should make comparisons with the current best alternative. And throughout history, actually, you can see two views of medical testing. And one, in fault of lacking a better term, I could call the essentialist perspective, and the other is the consequentialist perspective. And the essentialists, actually, which are now still dominant in the technology world and large sections of the medical world, says that the value of a marker of a medical test is judged by the trueness of its results. So analytical validity is an essential feature. Now, in contrast are the consequentialists. They are stating that the value of a marker or a medical test should be judged by the value of its consequences. And that means that we should look at the downstream consequences of using the test in a comparative test to say anything about the value of medical testing and to make claims that medical testing is effective. So who knows what will happen in that next visit when Mr. Metabolomics comes in again with the emergency department. Maybe he will bring Mrs. Hoegeburen actually evidence of the clinical utility of that new device, the PE sensor. But maybe he doesn't, because there are very few authorities nowadays that actually ask for proof of clinical utility before they're accepting a medical test. So I presented these three concepts for you. Let's see if I was able to convince you in these 20 minutes. What do you think is the most important feature in evaluating medical tests in Infarctum? And there's no option 4 that they're all important, which I would agree with. But what is the most important feature? Is it analytical validity, making sure that the results are true? Is it clinical validity, making sure that the results are meaningful in a clinical sense? Or is it clinical utility, the effects of medical tests on patient outcome? Thank you. Well, just as a coda, this device, the PE sensor, does not exist yet. Well, in a way, actually it does, because I took the picture from the internet, because this device is being sold actually to detect actually flesh that is very close to the limit of expiration. So to find out whether the flesh in your, the meat in your fridge is still any good. But the technology itself exists because people are toying around with breathomics as a diagnostic tool for pulmonary embolism. I really want to thank you for your attention and for being convinced also that clinical utility is a driving factor. Thank you very much.
Hi, I'm Braden O'Neill. I'm a DPhil student in the Department of Primary Care Health Sciences at Oxford. First of all, thanks for the talk again. And so you were fairly convincing that, that clinical utility is the most important aspect of any diagnostic test. But I want to contrast that with the tests you showed us in the initial part of the talk, where most of them had, absolute clinical utility, and yet maybe 50% of us on any given one said that we might take it. So I'm sort of interested in your thoughts on that discrepancy.
I think there's going backwards, actually, there's no clinical utility than having periodic examinations by a full body MRI actually leads to improved health. So I think you'll agree with that. There's also no evidence of the clinical utility of genome-wide scans, actually, and several expressions of pessimism and caution about genome-wide scans, actually, which for the majority of cases actually produce relative risks which are fairly moderate and which do not lead to any preventive measure that would differ from what any people would do under normal circumstances. So if you think about the clinical utility of genome-wide scans nowadays, actually, and compare it to other preventive measures, actually, there's no evidence about clinical utility and reasons to doubt it. That doesn't mean that I say that all genetic testing should be abandoned, actually, because that would require more detailed discussion. For the other examples, actually, there's debate about the clinical utility of colonoscopy screening, but to such an extent that there, again, actually, the principle about informed decision-making for the MVTs applies. So clinical utility does not mean, actually, that you should take it in all, under any circumstances. I think there is clinical utility proven and documented for periodic blood pressure measurements in people in certain specific age categories and risk categories. And the same applies also for lipid-lowering treatment indications in specific risk groups. So, but that doesn't mean, the examples that I show were all in a sense preventive, actually, and there actually the risk-benefit balance is somewhat different than the diagnostic problems that arise in other areas of medicine.
Yeah. Ruth Gilbert, thank you, Patrick, that was a fantastic talk. I wondered if you were implying that the licensing bodies should be taking up dealing with devices. Have you any thoughts as to how that might be taken forward?
Okay, well, a simple question and a complicated answer. Because right now, actually, there is movement in that area. So the IVD manufacturers actually are recognizing the changes in society where people are actually demanding for evidence of clinical utility before making decisions definitely about reimbursement and sometimes even about marketing. So I think the manufacturers should start working on that. And there's an incredible difference between actually the manufacturers of drugs, which have been used to the principle actually of demonstrating effectiveness for more than, well, several dozens of years, and the manufacturers of medical devices actually, which have never been encouraged to think about it. And in this case, actually, I exaggerated my story because the person that developed the PE sensor actually knew what the intended use was. For many medical tests, actually, the manufacturers and developers have no idea about the intended use. So there should be a change there. And I think the easiest way actually to start is with the people responsible for reimbursements and maybe even for commission. They should be invited to look at clinical utility first, and they're already doing that. I see several organizations throughout the world actually demanding evidence, direct or indirect, of clinical utility before making reimbursement decisions, and actually keeping off tests with very good analytical validity because of the lack of proof about clinical utility. So it requires multiple parties to start thinking. Also us, actually, we should not be seduced by technology just because it produces beautiful pictures or reliable numbers. We should think about the downstream consequences in a comparative way.
Great talk. I've been trying to illustrate this point for several decades, and this is by far the best illustration that I've seen of it, so thank you for that. Here's my question. First of all, I voted in the 84%. I think clinical utility is the most important, but what I experience when I look at research and attempt to decide whether to change practice is that there's never, ever a study connecting patient outcomes to the diagnostic test. I'll give you a specific example. There's a point-of-care test for chlamydia that's been evaluated. It appears to have analytic validity, clinical validity, if you set the standard at clinical utility, then here's my question. Do you then have to show that diagnosing chlamydia at the point of care is somehow has more utility than the usual process in which you lose patients to follow up and that sort of thing when they don't follow up with their test?
About how you would demonstrate clinical utility. Because there, the randomized clinical trials would be the ideal paradigm, but they're not always needed. But at least what we require is that if somebody presents you with evidence about let's say, the diagnostic accuracy of your chlamydia test, actually, that person designing the accuracy study was aware of the intended use application. So where exactly do you plan to use this chlamydia test? Would it be used for screening? Would it be used for diagnosis, actually, in a fertility clinic? And all of the intended use actually would lead the design requirements for an accuracy study. So I think clinical utility works through to evaluations of clinical validity and analytic validity as well. You should think about the intended use and think about the other levels as well, and should think about clinical utility when making and designing studies about the accuracy, diagnostic accuracy and the analytic validity. And for your chlamydia test, no, it will not always be required. Actually, if the test is there to replace another one, it may not be. But if thinking about chlamydia screening, actually, well, we may need evidence from screening trials, actually, that the downstream consequences are indeed beneficial to those screened. So sorry, this is maybe not very satisfactory, but it takes a longer discussion to think about clinical utility. And we must accept that in many cases there will only be indirect evidence. But at least when arguing about this, we should think about the downstream consequences and the patient outcomes.